Hello everyone. In this INR number 58, I'm going to tell you about multiple sclerosis. So, what is multiple sclerosis? This is an autoimmune demyelination disorder. Remember, whenever you see the word demyelination, that means myelin has been damaged. So, myelin has been damaged means which cell would be damaged? So, it is either oligodendrocyte in central nervous system or Schwann cell damage in the peripheral nervous system, right? So, that is what we are seeing in multiple sclerosis. Healthy neuron, you can see Schwann cells are intact, means myelination is intact, whereas in case of multiple sclerosis you can see there is a damage of the myelin sheath, right? This is demyelination, right? What is the risk and who will be commonly affected? So remember, female patients are commonly affected, which will be 20 to 40 years. What is the risk? Farther away from the equator they will be having risk, or even the low level of vitamin D. Remember, this is interesting point. Low level of vitamin D is also associated with multiple sclerosis. What will be the clinical finding? Most common clinical presentation in this patient will be relapsing and remitting. Remember, this is the most common clinical course: relapsing and remitting appearance. Acute multiple sclerosis, there is a one variant called as Marburg variant. What is Marburg variant? Marburg variant is a fulminant type of demyelination. Remember, there will be a rapid damage of the myelin sheath, and that will be progressing to death within 1 and 2 years. That is Marburg variant of the acute multiple sclerosis. In other features, what you are going to see in multiple sclerosis: optic neuritis. So what is optic neuritis? They will be having acute painful visual loss, and that will be unilateral. That is very important. Acute painful unilateral visual loss, and they will be associated with relative afferent pupillary defect, which is also called as Marcus Gunn pupil. So you can see Marcus Gunn pupil is shown here, right? When you are throwing light into the healthy pupil, they are contracting or constricting, whereas bright light, when you are projecting into the affected eye, they will be having dilatation of the pupil. That is Marcus Gunn pupil we are seeing in the optic neuritis of the multiple sclerosis. Another important feature is Charcot's neurological triad. So what is Charcot's neurological triad, which we see in multiple sclerosis? We can remember this by a mnemonic called SIN, right? SIN means scanning or staccato speech, right? Scanning or staccato speech. Then intentional tremor, when you will see the patient when they are reaching out for some object, they will be having intentional tremor when they are reaching closer, so that is intentional tremor. And nystagmus, right? So they will be having nystagmus. So scanning speech, intentional tremor, nystagmus, these are called as Charcot's neurological triad, which we will see in the multiple sclerosis, right? So relapsing remitting, most common clinical course: optic neuritis, Charcot's neurological triad, and there are two important signs: Lermite sign and Uchtdorf sign, right? So what is Lermite sign? Electric shock like radiating or shooting pain. Remember, electric shock like radiating or shooting pain where? In the cervical spine. In the cervical spine, when we are doing the flexion of the neck. So when you are doing flexion of the neck, you will see there is a shooting pain into the cervical spine, that is called as Lermite sign, which you see in case of multiple sclerosis. What is Uchtdorf sign? Symptoms may exacerbate on increasing the body temperature. Whenever body temperature will increase, all the symptoms will be intensified, they will be increased, or they will be aggravated. So that is called as Uchtdorf sign. Temperature, when it will be increased, it can be because of hot bath or it can be exercise. So there are various potential triggers. You can see hot and humid weather, direct sunlight, even the using hair dryer, exercise, or saunas, hot tubs or hot warm showers, even fever from any infections. That is why Epstein-Barr virus infection is also suggestive of the multiple sclerosis, and hormonal fluctuations, right? What will be the diagnostic thing when we are coming to see the CSF finding? CSF will be having increased IgG level. So remember, immunoglobulin G level will be high in the CSF, and because myelin has been damaged, right? You remember, myelin has been damaged because of demyelination. So myelin basic protein will be also increased in CSF. So increase IgG, increase myelin basic protein will be also there, and they will have characteristic oligoclonal bands which will be helping in diagnosis, right? When you will see MRI, MRI is investigation of choice to confirm the diagnosis of multiple sclerosis. So remember, it is investigation of choice. And what are the two things which we are going to use by MRI? Dowson fingers we are going to identify, and second thing, we are going to use the McDonald's criteria for diagnosis of the multiple sclerosis. So Dowson fingers are periventricular plaques. So you can see these are the Dowson fingers, and these plaques are formed because of damage of oligodendrocyte, right? Oligodendrocyte has been damaged, and reactive gliosis is going to show you these plaques, right, which we are seeing, and we are calling this as a Dawson fingers, which is very specific sign for the multiple sclerosis. And McDonald criteria is used for diagnosis in multiple sclerosis, where you will see multiple white matter lesions, which are disseminated in space and time, right? So that is what we are going to use for diagnosis by using MRI, McDonald's criteria, right? VEP, what is visual evoked potential? When you will see the visual evoked potential, obviously myelin has been damaged. So when suppose left eye is damaged, so visual evoked potential, you will see the slow or delayed conduction. So that is why you can see latency is normal here by this one. But in case of left eye damage, you can see there is a delay of 32.2 millisecond, right? So this is important. Latency will be present in the affected, or in a simple word, visual evoked potential, you will see the delayed conduction in multiple sclerosis. This is a point which I observed in the Harrison 21st edition on this page number. Because examiner can ask you this question: expanded disability status scale, EDSS, right? Expanded disability status scale is used for measurement of neurological impairment in multiple sclerosis. Remember, this is used for measurement of neurological impairment in multiple sclerosis. This examiner can ask you, what is the use of EDSS score? If EDSS score is less than 3.5, patient will walk normally and they are not disabled. If EDSS score is more than 4.0, they will have progressive multiple sclerosis, they will have abnormal gait, and they are occupationally disabled. So now you have to remember two things: less than 3.5 is normal, more than 4 is progressive, occupationally disabled, and they will be having abnormal gait. So these are important point about the expanded disability status scale. Expanded disability status scale, which is used for neurological impairment in multiple sclerosis, right? Treatment, see, I have highlighted some of the things like highly effective, highly effective. These are the lines of the Harrison. I should say these are the headings of the Harrison. If you open the Harrison and you look into these page numbers which I had mentioned, you will find all these things are in a bold letter and they are mentioned very prominently, so examiner can ask you. So I am dividing treatment into three portions: acute attack or initial demyelinating episodes, disease modifying therapies for relapsing form of the MS, and third one is symptomatic treatment. So for acute attack or initial demyelinating episode, we will use glucocorticoid, IV methylprednisolone example, we are going to use it. For disease modifying therapies, when we are going to use disease modifying therapy for relapsing form of the multiple sclerosis, where we are going to use anti-CD20 monoclonal antibody. Remember, anti-CD20 monoclonal antibodies are highly effective. This is the point you have to remember. And who are the example? Ocrelizumab, ofatumumab, and rituximab. These are three important drugs we have to remember. Natalizumab is also highly effective. What is natalizumab? Natalizumab is a humanized monoclonal antibodies, which are formed against alpha 4 subunit. Remember, alpha 4 subunit of alpha 4 beta 1 integrin, right? So they are formed against alpha 4 subunit of alpha 4 beta 1 integrin. They are present on the lymphocyte. So natalizumab will be active against this alpha 4 beta 1 integrin. This is another important thing. S1P, sphingosine 1 phosphate modulators, they are moderately effective. Fingolimod, ozanimod, or ponesimod. These are the drugs. Anti-CD52 monoclonal antibody. Again, this is a very important thing for exam. Anti-CD52 monoclonal antibody, they are highly effective, and the important drug here we are using is alemtuzumab. Right, so please remember, alemtuzumab can be our future question also. Symptomatic treatment we are using for neurogenic bladder spasticity or pain. For neurogenic bladder, we are using muscarinic antagonist or botulinum toxin injections. For spasticity, we are going to use baclofen or GABA B agonist. For pain, tricyclic antidepressant or anticonvulsant. So basically, we have to focus on these two things which examiner will be asking you, right? Acute attack, glucocorticoid, disease-modifying anti-CD20, ocrelizumab. Remember these drugs, and anti-CD52, which is highly effective alemtuzumab, right? So keep revising this topic for your exam. Best wishes for your exam.